Good morning, physiology class of Jose Maria College of Medicine. First things first, I would like to introduce myself. I am Dr. Lilibeth Araniego. I'm an internist and adult cardiologist. And before everything, I would like to share to you my favorite Bible verse, which is, I can do everything through Christ who gives me strength. Now, I would have preferred to have a synchronous type of lecture, of classroom, so that I can see you one by one and get to know you better. And we can also have an interaction probably of question and answer. But since there's a lot of glitches and PLDT interruptions, so we just have to do with the asynchronous type of learning. So the topic that was given to me is on cardiac output, venous return, and their regulation. This is a topic that is very basic in cardiology, but it takes a lot of mental challenge to understand and to go through one by one the different dynamics of cardiac output and venous return. I hope that you have read your books before coming to class today so that you may have a better grasp of what we will be talking about, and so that you can also formulate questions and take advantage of asking your teachers, because that is one way towards a good learning. Okay. So first, we start by defining what is cardiac output. Cardiac output is the amount of blood that is pumped by the aorta each minute into the systemic circulation. It is the quantity of blood that flows into the circulation. So it is the sum of blood that flows into all tissues in your body. And therefore, it is one of the most important factors to consider when you are talking about cardiovascular system. It's like you're asking, how is your heart? And the parameter to measure how your heart is cardiac output. So if you have a normal cardiac output, then you can say that your heart is strong, or maybe strong enough, most likely. Now, what are the normal values for cardiac output? Cardiac output varies widely according to the level of activity. So if the individual may be very active, then the cardiac output may be increased. The factors that directly affects cardiac output are the following: basic level of metabolism, exercise, age, and body size. Age is a factor because when we get older, we grow more age, we have decreased body mass. Skeletal muscles shrinks, and we also have decreased body activity, and therefore cardiac output may be decreased. Cardiac output varies in men and women depending on the muscle mass, adiposity, physical activity, metabolic rate, nutritional needs of your tissues. So what is a normal cardiac output? For young, healthy men, the average resting cardiac output would be 5.6 liters per minute. For women, the average resting cardiac output would be 4.9 liters per minute. But if someone will ask you, what is the normal cardiac output? For adult, you may just round it off and say that it's 5 liters per minute. Venous return. What is venous return? Venous return is the quantity of blood that flows from the veins going into the right atrium each minute. So where did all this blood came from? This blood came from the tissues which are collected by your venous system, which it will bring towards back to your heart via your right atrium. And right atrium will empty this blood into your right ventricle, and your right ventricle will pump this blood to your pulmonary artery to your lungs where gas exchange would occur, and this blood will be refreshed again with oxygen and will be brought back to your heart again via the left atrium, and then left atrium will empty out this blood to the left ventricle, and left ventricle will pump again this blood going out of your systemic circulation. So venous return is equally as important as your cardiac output. Venous return and cardiac output must be equal, except maybe for some circumstance when there is for a few heartbeats, or when blood is temporarily removed from the heart and lungs. Now this represents the cardiac output in the total tissue blood flow. So you can see from the picture that in your total cardiac output or total volume of blood in your body, it is splanchnic circulation, kidneys, which gets the lion's share of your cardiac output or the total blood volume in your body. And this is followed by your skin, muscles, and brain. And your heart gets only 4%. And you can see there the left heart system and your right heart system. Now, what is cardiac index? Is it the same as the cardiac output? Cardiac output increases approximately in proportion to the surface of the body. So cardiac index is also a parameter which is similar to cardiac output but expressed in per square meter of body surface area. So for example, you have a 70 kilogram 70 kilogram weight of a person, and the body surface area is 1.7 square meter. The normal cardiac index of that person would be 3 liters per minute per meter square of body surface area. It is said that cardiac index rapidly rises to 4 liters per minute per meter square when a child grows to 10 years old. However, through time, as we get older, our cardiac output also declines with the loss of skeletal muscles and loss of decrease in our activities, and so on and so forth. So cardiac index also may decline to 2.4 liters per minute per meter square when a person reaches the age of 80 years old. Cardiac output regulated throughout life in direct proportion to metabolic activity. That's why we said that when we grow older, our metabolic activity decreases, and therefore our cardiac output also decreases. So declining cardiac index is equivalent to declining activity, which means that there might also be declining muscle mass due to age. Now this figure would just show you a cardiac index for a person and in relation to age. So the cardiac output per square meter of surface area at different ages. At 10 years old, there is what we talk about, the spurt of cardiac index to a certain level, but as the years go by, the cardiac index declines through age. Now, what is Frank Starling mechanism of the heart? The heart pump function or the contractility function of the heart is crucial in determining your cardiac output. But is it the primary controller of cardiac output? No. The primary controller of cardiac output is your venous return and various factors that affects venous return as well. So in our body, we have a built-in mechanism that allows the heart to pump automatically the blood that flows from the veins into the right atrium without delay. The Frank-Starling law states that when there is an increased quantity of blood flows into the heart, the increased load that stretches the heart walls of the heart chambers results to increased heart contractility, and this ejects extra blood into the systemic circulation. Other important factors are as follows. Stretch of the sinus node. So when there is stretching of the heart, the sinus node is also being stretched. Sinus nodes are small tissue which is almost invisible to the naked eye and found embedded in the right atrium, and this is called also as the natural pacemaker of the heart. So all the impulse of our heartbeat are coming from this tiny thing, sinus node in that right atrium. So if the venous return empties its blood into the right atrium and the right atrium stretches, sometimes it also stretches the sinus node, and the sinus node results or responds by increasing heart rate by 10 to 15%. Now, what is the Bainbridge reflex? Bainbridge reflex is the stretching also of the right atrium, which initiates nervous reflex, passing first to a vasomotor center of the brain and then goes back to the heart by the way of the sympathetic nervous system and the vagus. And this also increases the heart rate. So in normal, unstressed condition, cardiac output controlled mainly by peripheral factors that determine your venous return. Excuse me. If the returning volume is too much for the heart to pump, the heart becomes the limiting factor that determines the cardiac output. Okay? So, the limiting factor that determines cardiac output is your venous return and the factors that affects venous return. However, in some circumstance, when the returning volume or the venous return is too much for the heart to handle, and the heart cannot effectively pump everything that is being loaded into it, it becomes now the limiting factor than your venous return. So there are also important points that I would like to note to you. Cardiac output is the sum of all the tissue blood flow. If you must think the circulatory system, heart and the circulatory system is a closed circuit. Okay? So the 5 liters of blood that runs through it is in a closed circuit, and therefore the cardiac output is the sum of all tissue blood flow. Tissue metabolism regulates most of the local blood flow. And all local blood flows, they summate, they converge, and they become those blood that are being collected by your venous system to go into venous return, to be emptied into right atrium, and the right atrium empty the blood to the right heart system into the lungs, and from the lungs goes back to the left heart system and the left heart will pump the blood into your aorta and it goes back to systemic circulation. The venous return is the sum of all blood flow through all individual tissue, therefore, segments of peripheral circulation. Blood flow increases mainly in proportion to tissue metabolism. Increased tissue oxygen consumption also increases local blood flow. Increased exercise, increased cardiac output, increased oxygen consumption. So if a patient or if a person exercises, there would be an increase in oxygen consumption. And this would lead to an increase in cardiac output. Now this slide will show you the cardiac output in the red line and cardiac index, and the blue line is your oxygen consumption. So it is very obvious, you can see right from the graph, that as your oxygen consumption rises upward, your cardiac output and cardiac index also rises upward. So there is a linear upward relationship between cardiac output and oxygen consumption. Cardiac output is inversely related to your total peripheral resistance when arterial pressure is unchanged. Total peripheral resistance is the resistance in the peripheral blood vessels, resistance to flow. Okay? So when cardiac output is said to be inversely related to your TPR when your arterial pressure is unchanged. So this is an important principle in cardiac output control. Your total peripheral resistance is normal. Your cardiac output must also be normal. If your total peripheral resistance is increased above normal, your cardiac output must be decreased. If your total peripheral resistance is decreased, your cardiac output must increase. So this is Ohm's law, and you can read that further, and maybe you have learned that already in the earlier chapter. So cardiac output can also be computed by this formula: your arterial pressure divided by your total peripheral resistance. So cardiac output, that's cardiac output divided by your total peripheral resistance. This figure here just show you the arterial pressure, cardiac output, and the total peripheral resistance. And this figure also marked each point with the different diseases or different clinical conditions like beriberi, AV shunt, anomaly, hyperthyroidism, and anemia. So you can see here from this figure that the cardiac output for beriberi is very high. These are conditions with high cardiac output, AV shunts, and hyperthyroidism. And as the total peripheral resistance goes down, we see their hypothyroidism and removal of both arms and legs. Okay? Yeah. So limits of cardiac output. There are definite limits also to the amount of blood that the heart can pump. And this is expressed quantitatively in the form of cardiac output curves. In the next slide, we will show you a figure 20-5 lifted from the book, which shows the normal cardiac output curve. So this is your cardiac output curves for the normal heart in the green line, and for hypoeffective below that, and for hypereffective heart above that. The normal cardiac output curve shows that the cardiac output per minute at each level of right atrial pressure. The plateau level of this normal curve is about 13 liters per minute, and that is 2.5 times the normal cardiac output. Okay, so this is your green line, which represents your normal cardiac output, and the cardiac output here is 13 ml per minute at the level of right atrial pressure of 4. Okay, So 13 liters per minute is 2.5 times the normal cardiac output of 5 liters per minute. This means therefore that the human heart functioning without any special stimulation can pump a venous return of 2.5 times the normal venous return before the heart becomes a limiting factor. As shown in this curve, also is the cardiac output for hearts that are not functioning normally, such as your hypereffective heart, which is represented by the blue line here, okay, and the hypoeffective heart, which is represented by this space here. Hypereffective heart are those that pumps better than the normal, while the hypoeffective heart are those that pumps below the normal. Now, what are the factors causing this hypereffective heart? There are two general types of factor to make the heart pump strongly than normal. One, the nervous stimulation, and two, hypertrophy of the heart muscles. Again, there are two important factors that makes the heart a stronger pump than the normal: nervous stimulation and your hypertrophy of the heart muscles. Nervous stimulation. It is a combination of your sympathetic stimulation as well as your parasympathetic inhibition. And this results to increase heart rate greatly, especially among the young people who may have a resting heart rate of 70 beats per minute. But with sympathetic stimulation and parasympathetic inhibition, this heart rate may go to as high as 180 to 200 beats per minute. For young individuals, this may be nothing, but for elderly who have a very limited cardiac reserves, this 180 to 200 beats per minute may result already to difficulty in breathing. Now, aside from that, sympathetic stimulation and parasympathetic inhibition may also increase contractility of the heart. The force of contraction may increase to 2 times normal. So increased heart rate is called chronotropicity, and increased contractility is called inotropicity. So with this combination of nervous stimulation, you will say that there is an increased chronotropicity of the heart as well as increase in the inotropicity of your heart. So if you combine the effect of increased chronotropicity and increased inotropicity of your heart, this will raise the plateau level of the cardiac output curve to almost 2 times the normal, and that would result to a 25 liters per minute level of the uppermost curve. Now, how about heart hypertrophy? If there is a constant increased workload on the heart muscle will eventually increase. And that increase in heart muscle will also lead to increased contractile strength of the heart. For a marathon runners, for example, increase in heart muscle mass is estimated to be about 50% to 70% in some of them. And this heart muscle mass, as a result, will cause an increase in the plateau level of cardiac output to 60% to 100%. Therefore, the heart pumped much greater than usual amounts of cardiac output in the marathon runners who have an increased muscle mass of 50 to 75% than above the normal. Combining nervous stimulation with hypertrophy, what will happen? If you combine nervous stimulation with hypertrophy in a marathon runner, the heart may pump up to 30 to 40 liters of blood per minute. That is 2.5 times the levels that anyone can be achieved by the that can be achieved by the average person. Factors that affect, how about the hypoeffective heart? Meaning to say, these are the heart that pumps below than the normal. Factors that affect hypoeffective heart are the following. Any factor that decreases the heart's pumping ability can cause hypoeffective heart. So the different conditions are the following, are examples of a hypoeffective heart. Severe hypertension. The increase in arterial pressure against which the heart must pump can cause a hypoeffective functioning heart. Inhibition of nervous excitation of the heart. Pathologic factors that causes abnormal heart rate and rhythm. Coronary artery blockage, exemplified by myocardial infarction, which will be discussed in the further chapters as we go along. Valvular heart disease, congenital heart disease, myocarditis, and cardiac hypoxia. This is a graph that would show us the relationship of arterial cardiac output and the effect of nervous control. This experiment was done in a dog to demonstrate the importance of nervous maintenance of the arterial pressure as a prerequisite for your cardiac output control. So in this experiment, they used a dinitrophenol, which is a vasodilator, and shows you here the red lines are those with nervous control, and the dashed blue line are those without nervous control. So when the vessel is dilated, the nervous system controls the cardiac output. The arterial pressure here you can see is well maintained. It did not go down, but the cardiac output was able to go up. However, for those without nervous control, you can see there that the dilatory effect of the substance will cause a drop in the arterial pressure to as low as 50, while the cardiac output increased only by so much, by 1.6. Or the cardiac output is 1.6, which is very, very low. It's 1.6 times, and the decreased fall of arterial pressure is half the normal. Thus, we can say that the normal arterial pressure by nervous system reflex is essential to achieve an increase in cardiac output when peripheral tissues dilate their blood vessels to increase the venous return. Now, what is the effect of nervous system to increase the arterial pressure during exercise? During exercise, the metabolism of the active muscle increases, and this will cause relaxation of the muscle arterioles. The relaxation of muscle arterioles is brought about to allow oxygen, nutrients to sustain contractions. And the relaxation of the muscle arterioles will decrease the total peripheral resistance. If the total peripheral resistance decreases, this would therefore lower the arterial pressure. But do we really want a lower arterial pressure when you are exercising? That could be dangerous because sometimes if the arterial pressure is lowered and you are performing a workload like exercise, not much or enough blood may go into circulation, and it might sometimes compromise the circulation in your brain, and you will end up with a patient who has fainted. So nervous system is always there to compensate for the drop in the arterial pressure. Nervous system would compensate for the decrease in the blood pressure or arterial pressure. Same brain activity sends motor signals to the muscles, and these signals to autonomic nervous system, which will excite circulatory activity, resulting to a large vein constriction. And this large vein constriction will increase heart rate, increase contractility of the heart. Increased heart rate and forceful contractile of the heart will therefore increase your arterial pressure, increase in your blood pressure. And this increase in the pressure will further force to push the blood flow to the muscles. So this signals to raise arterial blood pressure above normal serves to increase the cardiac output extra 30% to 100%. Local tissues, blood vessels dilate, and the increase in venous return and cardiac output above normal. The nervous system plays a key role in preventing the arterial pressure drop to disastrous level. So we have that fail-safe mechanism in our body, and therefore you can really say how great is our architect. This is pathologically high cardiac output. Pathologically high cardiac output conditions are caused by reduced in total peripheral resistance. None of it is due to excessive excitation. The decreased total peripheral resistance increases cardiac output. So let us look at one by one these different conditions and learn how they end up with a high cardiac output. What is the mechanism or pathophysiology why they have a high cardiac output? Beriberi. Beriberi is a common illness, common clinical conditions way in the past, but which we no longer see in present. I haven't seen one in my whole entire career because probably we have a very improved diet as well as vitamins which are available for each one before they get into this beriberi stage. So beriberi is actually insufficiency of vitamin B1 thiamine, which will diminish the ability of tissues to utilize some of the cellular nutrients so that the local tissue blood flow regulation compensates it by peripheral vasodilatation. Vasodilatation, so that means the total peripheral resistance decreases. As a result, decreased TPR, there would be an increase in the venous return. An increased venous return will increase cardiac output to 2 times the normal. AV fistula shunt, another high output condition, which is a mostly congenital problem, and there is a shunt between the major artery and the major vein. Since artery has a higher pressure than the vein, we therefore expect that the large volume of blood will flow from the artery into the vein through the shunt. Therefore, there is much flow into the venous system, and this will decrease the total peripheral resistance. And again, decreased total peripheral resistance will go through the cascade of increasing the venous return and increase in the cardiac output. Another condition of high output is your hyperthyroidism. So how does hyperthyroidism leads to a high cardiac output state? In hyperthyroidism, you have an increase in your thyroid hormone, and therefore you have an increased metabolism of tissues in the body. Increased metabolism of the tissue in the body would lead to increased oxygen usage, as well as increase in vasodilator products released from the tissues. They have not known yet what type of vasodilator products that are released from the tissues, but it was surmised that probably adenosine compounds. So with an increase in the oxygen usage and increased vasodilator products, this will decrease your total peripheral resistance. And again, it will go through the cascade of events that decrease in total peripheral resistance will lead to increase in the venous return, an increase in cardiac output as a result. The increase in cardiac output in hyperthyroidism could reach up to 40 to 80% above the normal. Another condition of high output is your anemia. Anemia is when you have a deficiency of your red blood cells. You have a low hemoglobin because of low RBC. Well, there are a lot of causes for anemia. You can have iron deficiency anemia, you can have leukemia, etc., etc. But in this topic, we are talking about decreased red blood cell concentration, whatever cause for that. When you have a decreased RBC concentration, it will lead to decreased viscosity of the blood because there are less corpuscular cells in the blood and therefore decrease in viscosity of the blood, easier to flow. There will also be decreased delivery of oxygen to the tissue because you don't have RBC much in your blood, then you also lack the oxygen carrying capacity or oxygen carrying red cells to deliver oxygen to your tissue. There would therefore be some degree of hypoxia to the tissue, and this will lead to local vasodilatation. The decreased viscosity of the blood will result to decreased resistance to flow because there are less red cells or cellular component of the blood and therefore less viscous, more smoother to flow. So decreased resistance to flow together with local vasodilatation is therefore this is expected to increase cardiac output. So that is why anemia can also produce a high cardiac output failure. What about pathologically low cardiac output conditions? For low cardiac output conditions, this means that the heart is hypoeffective, or meaning they are not contracting strongly or as effectively as the normal. Okay. So, what are the conditions that can cause low cardiac output? So we can divide the low cardiac output into two groups. Those with decreased pump effectiveness, cardiac factor. The pump has a contractile problem that it cannot pump strongly as expected or normally. And the other group belongs to a decreased venous return. So these are non-cardiac factor and peripheral factors are considered instead. So for decreased pump effectiveness, these are the following conditions. It can be exemplified by this following clinical condition. Severely damaged heart, unable to pump effectively and therefore unable to meet the needs of metabolic requirements of the tissue. So what are these conditions? Coronary artery disease, which is severe blockage of the coronary artery, exemplified by myocardial infarction. There's a complete blockade because of a thrombus or because of a ruptured plaque. Severe valvular heart disease. Okay? Well, you can have a lot of range of valvular heart disease like mitral stenosis, for example. So there is a stenotic valve, and therefore the heart, there is a limitation in the emptying of blood from your left atrium to the left ventricle. Eventually, the blood will dam back into the left atrium. There is an enlargement of the chamber of your left atrium. There is increased pressure because it is enlarged, and this pressure will be reflected into the pulmonary system, and this will increase pressure in the pulmonary system, which may result to pulmonary edema and congestive heart failure. And this pressure also reflected backward to your right atrium, right ventricle, and this may also enlarge. So for advanced stage of mitral stenosis, for example, you have a very enlarged heart but very low cardiac output because there is a limitation. The mitral valve is stenotic, and therefore blood cannot empty from your left atrium to your left ventricle, and therefore left ventricle is left with nothing to pump into the aorta and to the systemic circulation. Another clinical condition with decreased pump effectiveness and results to low cardiac output is your myocarditis. Myocarditis is inflammation of your heart muscles. Okay? Pericarditis is inflammation of the heart covering. Okay? So when you have myocarditis, inflamed heart muscles, the heart muscles cannot pump effectively, and so this patient can have very high troponin because there might be damage in the heart muscles. And when you do 2D echo in these patients, you would see that the heart, it may not be functioning adequately. And then next condition is cardiac tamponade. Cardiac tamponade is accumulation of fluid into the pericardial space. Pericardial space is the space between the pericardium, the tissue that covers the heart, and the myocardial tissue. So if fluid will accumulate in that portion, it will limit or restrict the heart from contracting because there is water there in that space, and the heart cannot open up, cannot contract freely. Okay? So in cardiac tamponade, it can produce low cardiac output because the heart is restricted, and therefore it cannot pump enough blood into the aorta. So other conditions are cardiac metabolic derangements, and there's a lot of those things which is we may not discuss right now, but in the future maybe. So another condition is your decreased venous return, or the non-cardiac peripheral factors. So what are these decreased venous return, non-cardiac peripheral factors? What are the conditions that can give you a decreased venous return? Number one example is your decrease in blood volume. Decrease in blood volume, how so? Example is, most common, hemorrhage. If a patient is hemorrhaging, losing so much blood, there would be a decreased filling of the vascular system. And because the patient lost blood, and there would not be enough blood to fill up the vascular system, and therefore it cannot create peripheral vascular pressures high enough to propel the blood back to the heart. Okay? So another example is acute venous dilatation. When the sympathetic nerve system becomes inactive for some reason, there is an acute venous dilatation. When sympathetic nerve system is inactivated, this can cause peripheral capacitative veins to dilate markedly. And if the veins dilate markedly, there would be a decrease in filling pressures. There would be no adequate pressure in the vein, and therefore it would result to blood pooling and delayed return to the heart. This is called the flaccid peripheral blood vessels. Flaccid. So another example is the obstruction of large veins obstruction of large veins. Obstructed by what? Thrombus formation. Okay? So it's so dangerous when you have a varicose veins, varicosities, and there may be thrombus formation there. This will obstruct the flow of blood in that vein and therefore obstruct the venous return, the path of blood that which are going to return to the heart, to the right atrium. So obstruction of the large vein cannot return the blood to the heart. Now, decreased tissue mass. What do you mean by decreased tissue mass? Decrease in skeletal muscle mass as a result of aging. Again, we said that in aging, the skeletal muscle shrinks and there's also a prolonged inactivity, prolonged or limited inactivity can result to decrease in the size of skeletal muscles. With decreased size of skeletal muscles, there would also be decreased oxygen consumption and therefore decreased blood flow needs of the muscle. And this skeletal muscle blood flow decrease will also decrease your cardiac output. And the last example, decreased metabolic rate of tissue. If there is a decreased metabolic rate of tissue, for example, prolonged bed rest, stroke patients who are limited to bed, patients who have a spinal problem, mobility problems, they are glued to the bed and this would lead to decrease in the oxygen consumption and nutritional needs of the muscle. Eventually, because of that, there would be decreased blood flow and decreased cardiac output. So example of this condition also is hypothyroidism. Okay? Hypothyroidism. Now, what is a cardiac shock? A cardiac shock is a state when the cardiac output falls so low that it results to tissues all over your body which begins to suffer nutritional deficiency. So how is it similar or related to circulatory shock? So it's almost the same, but circulatory shock is a state when, regardless of whether it's a cardiac problem or peripheral factors, which is the cause for the shock, but when the cardiac output falls so low, below the level that is required for adequate nutrition of the tissues, and therefore in this state, the person is not able to meet the metabolic, or the heart is not able to meet the metabolic demands of the tissues in the body, we say that this patient is in circulatory shock. Now, this is just a graph to show you that these are the cardiac output and the different clinical conditions which we have discussed in relation to that. So you can see there, beriberi has a very high cardiac output, AV shunts, hyperthyroidism, anemia, anxiety, pulmonary disease, pregnancy, Paget's disease, control, young adults, hypertension. But those with low cardiac output are those with cardiac shock, traumatic shock, severe valve disease, mild shock, and myocardial infarction. Cardiac output curves. So what are cardiac output curves? If you talk about cardiac output in a normal state condition, it is easy to say, oh, you have an increase in TPR, then you would have a decreased cardiac output. But when the situation becomes stressful, in extreme exercise, or when in circulatory shock or cardiac failure, then we need to quantitate in analyzing the cardiac output. So cardiac output curves are used in quantitative analysis of cardiac regulation, especially in those conditions that I have mentioned. So to do quantitative analysis, we must distinguish first two separate factors that concerns cardiac regulation. One is the pump ability of the heart. That refers to your cardiac output curve, contractility of the heart. Two, the peripheral factors affecting the flow of blood to the veins and returning to the heart into the right atrium. which is your venous return curve. So, the two important curves in quantitative analysis of cardiac output and the cardiac parameters are the following: cardiac output curve and venous return curve. So we put this together in the curve quantitatively and see how these parameters interact with each other to determine cardiac output, venous return, as well as your right atrial pressures. So there are external pressures in the heart. The normal external pressure is equal to the normal intrapleural pressure, and that is -4 millimeters mercury. The increased intrapleural pressure to -2 millimeter pressure from normal shifts the entire cardiac output to the right, while an increase in your intrapleural pressure to +2 millimeters mercury would require also an increase of 6 millimeter mercury in the right atrial pressure from normal pressure of -4 millimeter mercury. What are the factors that affects external pressures of the heart? These are the factors that affects the external pressures of the heart. One is your cyclical changes of intrapleural pressure due to respiration. When we inhale, we exhale, there would be changes in the intrapleural pressures. About 2 millimeter mercury in normal breathing, but it could be as much as 50 millimeters mercury for strenuous breathing. Breathing against a negative pressure. Breathing against a negative pressure can shift to a more negative right atrial pressure or to the left. Positive pressure breathing. Shift the curves to the right. Opening of the thoracic cage. There is an increase in the intrapleural pressure to 0 millimeters mercury, and this shifts the cardiac output curve to right by 4 millimeters mercury. Again, cardiac tamponade, accumulation of fluid in the pericardial cavity, which increases cardiac pressure and shifts the curve to the right. Tamponade shifts upper portion of the curve than the lower portion because tamponade pressure increases to higher values as the chamber of the heart fails to increase the volume during the cardiac output. So this figure just shows you here the relationship of your cardiac output as well as your right atrial pressure. So with a normal intrapleural pressure of -4, you can see here your curve. While the intrapleural pressure decreases to 5.5, it moves to the left of the curve, and intrapleural pressure increases to +2 millimeter, it moves to the right. So this one occurs at the right atrial pressure of 4. Okay, and this is your cardiac tamponade. Okay, so another figure here is your combination of two major patterns of cardiac output curve showing the effect of alterations in both your extracardiac pressures and effectiveness of the heart as a pump. So your normal curve, the red line here is your normal line, okay, which is at 5 liters normal cardiac output, right atrial pressure below 0, okay. And this one, the dashed line here shows the hyper-effective heart with increased intrapleural pressure and hypoeffective heart with reduced intrapleural pressure. So the figure shows that the final cardiac output curve can change as a result of simultaneous change in the following: external cardiac pressure and the effectiveness of the heart as a pump. the increase in intrapleural pressure here, plus hypereffective heart, or the heart that is contracting forcefully above the normal, there is a maximum level of cardiac output due to the increased pump capabilities. Cardiac output shifts to the right because of the increase in intrapleural pressure. Okay, but this one here is hypoeffective. The heart is not pumping adequately, and therefore the maximal cardiac output plateaued at this level. Now, venous return curves. There are three principal factors that affect venous return. One is your right atrial pressure. The right atrial pressure exerts backward force into the veins, and this may impede the flow of blood into the right atrium. Two is the degree of filling of the systemic circulation. This is what you call the mean systolic filling pressure. Mean systolic filling pressure is the pressure that is measured everywhere in your circulation when all the blood flow is stopped. Okay? So all the blood flow is stopped. How can that be possible? And we are correct in saying that it is not possible to measure it in a live patient, in a live person, because you have to stop the flow of blood. Okay? So this is the pressure measured everywhere in the circulation when all the flow is stopped. So number 3 is the resistance to blood flow. Resistance to blood flow, that is resistance between the peripheral vessels and right atrium. Okay? So between peripherals and the right atrium. Cardiac output curve relates to the pump action of the heart to right atrial pressure, while your venous return curves relates to the flow of blood in the veins to the heart and relates it to the right atrial pressure. So this figure here, figure 20-10, shows you the normal venous return curve. So as you can see there, venous return and in relation to your right atrial pressure. So a normal venous return of 5 liters per minute at the right atrial pressure of 8. So this one here plateaued. So at the normal right atrial pressure of -4, the venous return is this much. But as the right atrial pressure goes up, the plateau also starts to go down slope until it reaches 0. And the 0 is the mean systemic filling pressure, which is 7 millimeter mercury, the normal mean systemic filling pressure. So what causes the plateau is the collapse of the large vessel veins entering the chest when the right atrial pressure falls below atmospheric pressure. Note also that the venous return becomes 0 when the right atrial pressure rises to equal the mean systemic filling pressure. Okay? So, if the right atrial pressure is below the atmospheric pressure, less than 0, what happens? The right atrium will create a suction. It's like vacuum, no? It sucks out the blood from the venous system, the large veins that goes back to the heart, and therefore sucks out the blood, and therefore the venous return here is on this level. But as the pressure also goes down, the venous return starts to decline and even reach up to 0, wherein the right atrial pressure also rises to 7 millimeter mercury, and this point is what you call the mean systolic filling pressure. So there are things I again listed for you, important for you to remember. Okay, when the heart pump decreases, your right atrium pressure increases. Your venous return decreases. If your venous return approaches zero, when your right atrial pressure increases to 7 millimeter mercury, which is by definition is the mean systemic filling pressure. The decrease in your venous return due to the increase in right atrial pressure, the heart pump also approaches zero because of decreased venous return. Both the arterial and the venous pressures reach an equilibrium when all the flow in the systemic circulation ceases or stops at a pressure of 7 millimeter mercury, which is the mean systemic filling pressure. So when the right atrium rises up to 7 millimeters mercury, there would be an equilibrium. Both the arterial and venous pressure reach that equilibrium. Plateau of the venous return curve at negative right atrial pressure is caused by the collapse of the vein entering the chest wall because the right atrium sucks out the blood from the large veins and therefore it creates a negative pressure. The right atrium sucks the walls of the veins as they enter the chest. Right atrium of 0 millimeter mercury, which is there would be no venous return flow. Okay, so if your right atrial pressure is zero, there would be no venous return flow, and the right atrium further falls to minus 2 millimeter mercury. The venous return plateaus, and the venous return remains to be in the plateau, regardless if the right atrium further falls at minus 20 millimeter or 50 millimeter mercury. Okay, so let me again explain that. So if your venous return here is 5 ml, and then atmospheric when the right atrial pressure is at zero, there will be no more flow into the venous into the right atrium from the venous return, and the venous return plateaus. If the right atrial pressure decreases further to minus 2, minus 3, and minus 4, this one plateaued and it remains on a plateau even if the right atrial pressure reaches minus 20 or even minus 50. But if the right atrial pressure increases to plus 2, the venous return also starts to fall down. Plus 4 at this level, and at 7, it reaches at 0, which is the mean systemic filling pressure. The mean circulatory filling pressure. This is an equilibrated pressure level. Without the blood flow, pressures everywhere in the circulation becomes equal. So the increased blood volume increases your mean circulatory filling pressure because it stretches the walls of your vasculature. So this again is show you the effect of changes in the total volume on the mean circulatory filling pressure. So the green is the strong sympathetic stimulation, the red is the normal circulatory system, the blue is the complete sympathetic inhibition, and the dot here is the normal volume. Okay, so this figure 20-11 is a curve that shows the effects of strong sympathetic stimulation as well as sympathetic inhibition. But not only that, it also approximates the normal effect of different levels of blood volumes on the mean circulatory filling pressure. So at the 4,000, So at the 4,000 ml of blood, you can see here that the mean circulatory filling pressure is close to, the 4,000 ml of blood, the mean circulatory filling pressure is close to 0. But at 5,000 liters of blood, the mean circulatory filling pressure is at 7 millimeter mercury, which is the normal value. But the higher volume of blood, the mean circulatory filling pressure increases also linearly. So with 6,000 ml, 7,000 ml, this filling pressure also increases linearly. The mean systemic filling pressure, or the PSF, is slightly different from your MCFP, the circulatory filling pressure. The mean systemic filling pressure is the pressure everywhere in the systemic circulation when all the blood flow is stopped by clamping the large vessels at the heart. And this is almost always nearly equal to your mean circulatory filling pressure because pulmonary circulation has less than 1/8 as much capacitance only and 1/10 as much blood volume. Okay, so mean circulatory filling pressure includes your pulmonary circulation, while your mean systemic filling pressure clamped large vessels at the heart, and therefore it does not include the pulmonary circulation, but is almost touted to be negligible because pulmonary circulation anyway has less than 1/8 as much capacitance and only 1/10 as much blood volume. So again, it is almost impossible to measure the mean systemic filling pressure in live animals. The normal mean systemic filling pressure is equal to 7 millimeters mercury. So this shows you the venous return curves showing the normal curve when the mean systemic filling pressure is 7. Okay, here, the red is the normal. This is 7 millimeters mercury. Okay, and this is your venous return. If your mean systolic filling pressure goes down to 3.5, at 3.5, this is your venous return at right atrial pressure of 4 millimeters mercury. Okay. So while complete SNS sympathetic nerve system sympathetic inhibition relaxes both the blood vessels and the heart, there is a decreasing mean circulatory filling pressure. Okay. So wait, in figure 2011, you can also see here that the curves are very steep, meaning slight changes in these blood volumes may cause slight changes in the blood volume or capacity of the system can cause various level of sympathetic nervous activity that can have large effects on your mean circulatory filling pressure. Again, what is the difference between mean systemic filling pressure and mean circulatory filling pressure? So they're almost similar to each other. It's almost always nearly equal to each other. Okay, so in figure 20-12, this shows the effects on your venous return by the increase or decrease of your mean systemic filling pressure. So note that the normal mean systemic filling pressure is 7 millimeters mercury. So for the uppermost part of the curve, the systemic filling pressure increases to, this one, the green, increases to 14 millimeters mercury. And the lowest more level is a mean systolic filling pressure of 3.5 millimeters mercury. So this curve demonstrates that the higher the mean systolic filling pressure, which also means that the greater the tightness with which the circulatory system is filled with blood, the more the venous return curve shifts upward to the right. Okay? Upward to the right. Upward to the right. And conversely, the lower is your mean systolic filling pressure, which in this curve, the lowest is 3.5. The more curve shifts also downward, downward, and to the left. Okay. Therefore, the greater the degree to which the system is filled, the easier it is for the blood to flow into the heart. But the lesser the degree to which the system is filled, the more difficult it is for the blood to flow into the heart. Okay? So the greater the degree to which the system is filled, the easier it is for the blood to flow into the heart. But the lesser the degree that the heart is filled, it is said that the flow is more difficult going to the heart. So right atrium is equal, if the right atrial pressure will be equal to the mean systemic filling pressure, there will be no flow. Zero flow, zero venous return. Okay? Right atrial pressure is less than the mean systolic filling pressure, there will be increased blood flow. So the greater the difference between the mean systolic filling pressure and the right atrium, the greater would be the venous return. And the difference between the mean systemic filling pressure and right atrial pressure, therefore, is called the pressure gradient for venous return. Okay, so remember that. The pressure gradient for venous return is the difference of the mean systolic filling pressure and the right atrial pressure. And the greater the difference, the greater would be the venous return. If right atrial pressure is equal to the mean systemic filling pressure, there would be no flow. But if the right atrial pressure is less than your mean systemic pressure, there would be increase in the blood flow. Resistance to venous return. So your mean systemic filling pressure represents a pressure pushing the venous blood from the periphery to the heart. The resistance to venous return is the resistance to the flow of blood that occurs mostly in the venous system. But it can also occur from the arterial as well as your small artery. So why is venous resistance very important in determining your venous return? The increase in resistance in veins versus arterial vessel. Okay, so let us look at how different it is if there is an increased resistance in the veins versus increased resistance in arterial vessel. So if there is an increased resistance in the vein, the blood damped in the veins, and this will build up little pressure because the veins are highly distensible. This will accommodate the pressure, and the pressure will not be enough to overcome the resistance. So the blood continues to dump in the veins. What about increased resistance in the arterioles or small arteries? So remember the venous anatomy and the anatomy of arterioles. Arterioles are more muscular than the veins. So the increased resistance in arterioles and small arteries, the blood accumulates in those vessels and the pressure raises similar to those in the veins. But the rise in pressure is so great and sometimes to as much as 30 times as that of the veins. And the arteries have low capacitance, only 1/30th that of the vein. So this increase in pressure overcomes the resistance and the blood therefore flows more in that arteriole than compared to those in the veins, because the resistance is overcome by the pressure that builds up in that vessel. So venous return can be calculated by the following formula. Venous return is equals to the mean systemic filling pressure minus your right atrial pressure over your resistance to venous return. So in healthy adults, you have a 5 liter per minute venous return. That is mean systolic filling pressure normal of 7 millimeter mercury minus the right atrial pressure normal of 0 millimeter mercury divided by the resistance for venous return, which is 1.4 millimeters mercury, and you get a venous return of 5 liters per minute. Okay, so this figure 2013 is a venous return curve that depicts the effect of altering the resistance to venous return. Okay, so venous return in relation to the right atrial pressure. The normal, here's the red line. You can see there that at 5 liters per minute of venous return, it goes down at 7 millimeters mercury, which is the mean systemic filling pressure. So in this graph, it depicts that the decreased resistance to half normal, it allows 2 times as much flow of the blood. Okay, so resistance, the normal resistance here, the red line, if the resistance here is decreased to half of that, then it allows 2 times as much flow of the blood. Therefore, this rotates the curve to upward and to the right. Okay, upward and to the right. While an increase in resistance to 2 times the normal, here, increase in resistance 2 times the normal, rotates the curve downward half as great as a slope downward. Okay, it rotates the curve downward. So the right atrial pressure increase, the mean systolic filling pressure, the right atrial pressure increase is equal to the mean systolic filling pressure equals to the venous return to 0 at all levels of resistance to venous return because there is no pressure gradient. So here, if the right atrial pressure increases to 7 millimeter mercury, which is equivalent to the normal mean systolic filling pressure, there will be no venous return, 0 venous return at all levels of resistance because there is no pressure gradient. Therefore, the highest level that the right atrial pressure can rise, regardless of how much the heart may fail, is equivalent to your mean systemic filling pressure. Again, I will repeat that. The highest level of the right atrial pressure that can rise, regardless of how much the heart may fail, is equal to the mean systemic filling pressure. Okay. So in this graph, figure 2015 shows you here the 2 solid curves demonstrating an analysis of cardiac output and the right atrial pressure when the cardiac output in the red line and venous out return in the blue line. The curves are normal. Okay. Okay, the red line is your cardiac output, the blue line is your venous return, and these curves are normal. See, you have here a point A wherein the cardiac output and venous return at 5 ml at the right atrial pressure of 0. So those are the normal state of the circulatory system. Now what happens if you transfuse blood equal to 20% of the blood volume, which causes the venous return curve to become this curve? Okay. After transfusing 20% of blood volume, the venous curve moves upward and to the right and becomes this black dashed line here. So what happens? In a complete circulation, the heart and systemic circulation must operate together. So this means that your venous return must equal your cardiac output. The right atrial pressure is the same for the heart in the systemic circulation. Therefore, one can predict that your cardiac output and your right atrial pressure in the following. Determine the momentary pumping ability of the heart depicts in the form of cardiac output curve, and determine the momentary state of flow of your venous return, which is depicted by your venous return curve. And then we equate the curve against each other. Okay? So the point A here shows where the two lines meet, cardiac output and your venous return at 5 liters per minute with right atrial pressure of 0 millimeters mercury. So the red line, normal cardiac output, the blue line, your venous return curve, and the dashed line is when the venous return after transfusing 20% of blood volume. The cardiac output and the right atrium shifts from point A to point B. Shifts point A to point B. So after a transfusion of 20% of blood volume, the cardiac output now becomes 13, 13 ml, 13 liters, and then the right atrial pressure rises at a right atrial pressure of 8 millimeters mercury and a venous return here. So at point A, the venous return is equal to the cardiac output. The right atrial pressure is same for both at 0. In the normal circulation, point A is what you call the equilibrium point. Equilibrium point, that is cardiac output of 5 liters per minute, venous return of 5 liters per minute with an RA or right atrial pressure of 0 millimeters mercury. So point A again is what you call your equilibrium point in the normal circulation. Point B is after transfusing 20% of blood, and this blood volume, after blood transfusion, the cardiac output increases to 2.5 to 3 times the normal. 2.5 to 3 times the normal here. Okay, and this distends the blood vessels. And once it distends the blood vessels, there is decrease in resistance. Decrease in resistance to venous return rotates the venous return curve upward. And the mean systemic filling pressure here is 16 millimeters mercury, which also shifts the venous return curve to the right. So as an effect, the cardiac output here at point B increases 2.5 to 3 times the normal, with the right atrial pressure increase of 8 millimeters mercury and the mean systolic filling pressure of 16 millimeters mercury. The venous return curve shifted to the right. So what are the compensatory effects initiated in response to increased blood volume? It is said that whenever there is an increase in blood volume, in just a few minutes there would be compensatory effect that would attempt to return the blood into its normal level. So the great increase in cardiac output by increased volume lasts only for a few minutes because several compensatory mechanisms would immediately begin to occur. So what are these compensatory mechanisms? One, increased capillary pressure. With increase in capillary pressure because of additional blood volume, this will increase in capillary pressure will overcome the oncotic pressure in that vessel, and this will transsude out the fluid into the tissues, returning the blood volume to normal. 2. Increased pressures in the vein. Veins continue to distend through a mechanism called stress relaxation, and this causes the blood reservoir. So we have a blood reservoir in our body in the form of the liver and the spleen, and they will distend, and this distension is in attempt to reduce the mean systemic filling pressure. The third compensatory effect is the autoregulation, which increases peripheral vascular resistance and increase resistance to your venous return. What are the effects of sympathetic stimulation to cardiac output? Sympathetic stimulation to cardiac output affects the heart, and not only the heart but also the systemic circulation. It will cause a strong pump, increase in contractile force, and increase in the mean systolic filling pressure as well. Okay? So this one is another figure which depicts analysis of the effect on cardiac output on moderate sympathetic stimulation from point A to point C, and maximal sympathetic stimulation at point D, and sympathetic inhibition caused by the total spinal anesthesia at point B. So here you can see the red again is the normal cardiac output curve. The normal cardiac output plus the venous return curves are depicted. This equates with each other at point A. In point A, there is a normal venous return and a normal cardiac output of 5 liters per minute and a right atrial pressure of 0 millimeter mercury. Okay, so point A, where the cardiac output and venous return equates with each other, 5 liters per minute in volume with a right atrial pressure of 0 millimeters mercury. At maximal sympathetic stimulation, what happens here in the green curve, there is an increase in the mean increase in the mean systemic filling pressure to 17 millimeters mercury, and this would shift the curve towards the right, and this is depicted by the point at which the venous return curve reaches 0, okay, and the venous return curve at 0, okay. There is an increase in pumping effectiveness of the heart by nearly 100%, and therefore it sends the cardiac output to a maximal level. So the maximal sympathetic stimulation results to increase in the mean systolic filling pressure to 17 millimeters mercury at point where the venous return is 0, and there's also an increased pump effect of the heart by 100%. As a result of this, there would be increase in cardiac output, increase to double the normal from point A to your point A to your point D, which is the RA pressure, which RA pressure hardly changes. Okay? The different degrees of sympathetic stimulation can increase cardiac output to 2 times the normal for short periods. Compensatory effects occur within seconds or minutes to return or attempt to return the cardiac output to near normal. So the effects of sympathetic inhibition here. Sympathetic inhibition by giving spinal anesthesia. So when the sympathetic nervous system was blocked by anesthetic, the total spinal anesthesia blocks the transmission of the signals to the autonomic ganglia. So that demonstrates the following. The mean systolic filling pressure falls to 4 millimeters mercury here. Okay. The effectiveness of the heart pump decreased to about 80%. So the heart pumps is about 80%, but it's still able to put up a cardiac output at this level. And the cardiac output falls from point A to point B. Okay, and decreased to about 60% of normal. Again, the spinal anesthesia blocks the transmission to your autonomic nervous system. And what happens is that the mean systemic filling pressure drops to plus 4 millimeters mercury, while the cardiac output also drops from point A to point B, which is a drop of 60% of the normal cardiac output. That is sympathetic inhibition. Okay. So this will be the last, I think, the last slide, the figure 2017 in your book. And this is an effect of opening of a large arteriovenous fistula. Figure 2017 is an analysis of successive changes in the cardiac output as well as your right atrial pressure in the human subject after a large arteriovenous fistula is suddenly opened. So the stages of the analysis as shown by the equilibrium points are as follows. A is the normal condition. B is immediately after opening the fistula. C is 1 minute or so after the sympathetic reflexes have become active. And D, several weeks after the volume has increased and the heart has begun to hypertrophy. So these are the changes here. Two red curves crossing at your point A. Okay? Two red curves crossing your point A. This is the normal condition. Okay? Wherein the venous return and cardiac output is 5 liters at right atrial pressure of 0 millimeters mercury. At point B shows a circulatory condition. Immediately after opening the large fistula, the principal effects are as follows. There is a large decrease in resistance to venous return when blood is allowed to flow with almost no impediment directly from the large arteries into the venous return. So there is a sudden precipitous rotation of the venous return curve upward. Okay? From here, sudden upward rotation of the venous return at the point B. So opening of the fistula decreases peripheral resistance. There is an acute rise in the arterial pressure and the heart pumps more easily as a result. And there is an increase in cardiac output from 5 liters to 13, here from 5 liters at point A to 13 liters per minute. And the right atrial pressure also increases to plus 3 millimeters mercury. So that is immediately after opening the fistula. What happens 1 minute later at point C? Okay, 1 minute later, the sympathetic nervous system tries to restore the arterial pressure to normal, and this caused two other effects. One, the mean systolic filling pressure because of constrictions of all veins and arteries decreased to 7 to 9 millimeter mercury. Okay, 7 to 9 millimeters mercury. Further elevation of the cardiac output because of the sympathetic nervous excitation of the heart. The cardiac output from point B rises to point C at 16 ml per minute, while the right atrial pressure rises also at 4 millimeters mercury. Now what happens to point D? Point D is after several more weeks from the opening of